Welcome to the Progression and Health Podcast. This is episode number 50. I'm here with Micahel Ray. Micahel, do you want to introduce yourself?
Sure. I just first wanted to say thanks for having me on, Ross. I appreciate the time and meeting you and getting to chat with you. Introduction's always weird to me, but in a nutshell, I'm a clinician. So I've traditionally trained as a chiropractor, graduated in 2015, and I also have a Master's of Science in Exercise Science with a concentration in motor control and rehab. And I am an academic. I teach at a local college for their Health and Human Sciences department. So I'm a tenured track assistant professor. And then I also conduct research. So I'm a pain researcher.
And you also lift as well, which is really important, I think, to have the experience. Yeah.
I attempt to lift.
Hey, that's all we can do, right? That's, the best we can hope for. So straight off the bat, I'm thinking of a chiropractor, and in Ireland, we just have a physical therapist. It's quite limited, right? We just have a personal trainer. We have a physical therapist, which we call a physio, and then we have a GP, right? And a chiropractor, it's kind of like an unknown sort of area of health in Ireland. So tell me a little bit about a chiropractor. When would someone go to a chiropractor? Are they considered, like the first level of treatment, the first line of treatment, like the gold standard, or like, assume I know nothing. Assume this is the first time I've heard of a chiropractor, because some of my listeners in Ireland won't have heard of that.
Yeah, no worries. It's an interesting discussion, and it's kind of complex, and hence that, off recording, one of the questions you said you're going to write down about the number of titles in healthcare. But ultimately, in the United States, a chiropractor is someone who went to a doctoral program. They graduated with a doctorate of chiropractic. There are four national boards you must take, and then a fifth physiotherapy board you can elect to take, which I did. And then you have national accreditation for being a chiropractor, and then you have to go through state licensure as well. So I'm licensed in the state of Virginia. And so we are traditionally viewed as a musculoskeletal based clinician, albeit I'm positive there are people who would claim that we're more of a health based and wellness based clinician. Our scope of practice, which means like what is within our ability to consult on, diagnose, work up, and treat, is quite broad. And in my opinion, unnecessarily broad, because it gives people freedom to kind of work in some gray areas like nutritional consulting, supplements consulting, doing blood work and making recommendations based on, like, it gets into some very sticky areas that I personally don't go into. So I've traditionally practiced within the musculoskeletal realm. But you do have direct access. You also, by the federal standards of Medicare, Medicaid, have physician level status. So that gives you a lot of affordances. For example, a chiropractor can order imaging, X-ray, MRI, anything that they really need to do, ultrasound. The chiropractor can order blood work and urine analysis. So it is an unnecessarily broad scope, in my opinion. But yeah, you could consult. Most people are going to consult, I would say, for low back pain and neck pain, stuff like that. And they could be a primary point of contact. The consultation would involve, a pretty standard diagnostic workup, going through a subjective history, an objective exam, and then making, recommendations from there, either management related or follow-up investigations. It's very similar to a general physician, but without the ability to prescribe medication. And I would also just add to that, for my medical friends, that we are drastically undereducated in comparison to a general physician.
Yeah, it kind of sounds similar to a personal trainer in a way, with a lot less of the qualifications, because, there's so many types of different personal trainers and how they operate. And then just with the manipulations that you see, like the body manipulations and stuff. Does every chiropractor do that? Is that just like some specialize in it, some don't do it? How does that work?
Yeah, so I usually say we are ultimately a healthcare professional, right? And so we have a particular title that affords us particular licensure, that affords us a scope of practice and treatment abilities. So within that scope of practice, we have a wide array of treatments at our disposal. but that excludes a few key aspects. We are non-pharmacological management strategies, meaning we don't do medication prescriptions, we don't do injections, we don't do surgery, stuff like that. So within that availability of what we often call conservative management, we do things like spinal manipulative therapy, which is what you're referencing. You could do dry needling or acupuncture. You could do massage. You could do kinesiology tape. You could do cupping. A wide array of things are available that I don't do.
Got it. So it's not everyone that's going to be doing those. Yeah. Yeah, because I got it done before and I was just kind of like, this is interesting. I wasn't sure what to make of it. So,
Oh, well, now I'm curious. What was your experience?
Yeah. So I went to a chiropractor because he was at the gym I was working at, and it was like, free. Of course, I'm going to try it out. I'm intrigued. Apparently it offers a benefit. And I was kind of talking about, I went there with some kind of sort of niggles or like mild kind of, restrictions, pain that I had, nothing that would have prompted me to actually pay for someone to help me out. So I was kind of just getting the treatment just because I could. And yeah, it was a sort of a bizarre experience because it was like, professional, like really like, I would say I enjoyed it, but it was like, I was sort of just like, it left me with more questions than answers because I was kind of like, what actually happened? What's my prognosis going forward? I think the guy did like a manipulation like on my some part of my lower back and my neck, and afterwards I was kind of it's just something I've never experienced before. I'd never intentionally try and manipulate my body like that, so I wouldn't be going back, or I wouldn't even refer someone to do that because I would be like so uncertain of it.
What narratives were you given to rationalize getting spinal manipulative therapy?
Yeah, so I can't even remember what I was told, really. It was more like, this is a complimentary service, and any sort of kind of pain that you have, I think, let's just see, can we kind of work it out? I think I don't think there wasn't a whole lot of like, the process. It wasn't fully explained.
That's not unheard of. I'm not surprised by that, but I'm assuming it was under the guise of like you had X pain and X body region, and then we're going to do full spine manipulation because you need to be in alignment to get rid of this pain.
I think that's what it was kind of, it was kind of framed as like something was out of alignment and we're going to get you back. I think that's, the word alignment definitely came up. And it was kind of getting like relief, it's kind of like you've presented with this issue, this misalignment. We're going to realign you here and you're going to leave with less pain, basically. But it was about 2 years ago, so or over a year ago. So yeah.
What were your thoughts about those narratives?
I have like my undergrad and postgrad done, so I'm kind of just like very skeptical. Like what's the mechanistically what's going on here? Like why would it work? And it was so new to me as well. It's kind of like anything new that isn't kind of well established, I'm a little bit more skeptical of as well, coming from Ireland where we don't have it. So yeah, I definitely wouldn't be going back. I wouldn't, whatever it cost, I wouldn't have felt like it was worth the money that it would have been. Yeah.
What's interesting to me, right, is like spinal manipulative therapy isn't restricted to any particular healthcare title. So like physical therapist is capable of doing that. An osteopath is also capable of doing that. But if you talk to all of these different titles doing the same intervention, they'll give you different reasons for why it's needed to be done, right?
Yeah.
Which is really interesting to me because I'm like, how is it possible that we could all be doing the same thing, but under the guise of supposedly a different narrative, even from a mechanistic standpoint? So I think you're right to be skeptical. And my usual advice to folks, if that's all your healthcare professional is doing, then I would struggle to say you should go back to that clinician. It would be similar to saying that, if you're trying to address other health related factors and you go see a physician and they just say, well, we're just going to give you this medication. And you're like, well, are there other things I could be doing? And it's like, no, just take this. And that's not invalidating medication. There are absolutely scenarios and contexts that it should be a part of co-management for people. But to ignore the other healthy lifestyle behaviors that could also be addressed would be a disservice, in my opinion, meaning like what's physical activity look like, what's sleep look like, what's your social network look like, stuff like every healthcare professional should be going through in appropriate scenarios. Does that make sense?
Absolutely. And it's something I've noticed as well where, some of my coworkers will do stuff like massages or like assisted stretching, or even a guy who owns a gym was recommending to me, you want them to have a good session, you stretch them out. And I'm like, I'm not an advocate for stretching. Where's the evidence for stretching, Having said that, then it's like, you're making me think that for my own, work with clients, that the educational side's, fundamental. I can't just put them through a workout blindly and then they just keep coming back and relying on me. It's like I have to really incorporate an educational, or I already do, but it's kind of just like, it can't be kind of like client empowerment is really basically very important.
Yeah, and it's difficult, right? Like the system that we find ourselves in operationally is one in which I'm giving you financial gain and you're doing something to me or giving me something. And usually education is greatly undervalued in most contexts. I would say certain fields capitalize on education as a commodity quite well. Obviously, our school system, K through 12, and most especially higher education, which I work in, huge capitalistic endeavor. But also like other professions like lawyers do a very good job at you are paying me as a consultant for my legal knowledge to give to you. And they make it quite profitable. They usually charge an hourly rate. That doesn't tend to be the case in health and fitness and healthcare. It's rare in which you could do a consultation, provide education and strategies for self-management, and there's a high value return on that financially. People in these contexts want to be told what's the problem and how can you help me fix it, or how can you fix it for me? And I think that bleeds into health and fitness as well. It's not, hey, here's these physical activity guidelines that we have. Really, we just need to be making moves towards that. Here's how we could do that based on your lifestyle, your financial abilities, so on and so forth. And then this is something you needed to sustain towards, from in essence all the way until the grave. That's not that. It's tell me the, super special secret diet no one wants you to know about that I should be eating. Tell me these 3 trick exercises that'll get me shredded and ripped, but also hypertrophy at the same time. And it's like the things that are actually high value information and variables in both of our fields are drastically undervalued on many fronts, but especially financially. And we elevate these things that we think are going to be quick fixes to these perceived outcomes we want to achieve.
Yeah, it's like what works isn't sexy, and what sexy doesn't work. Yeah, it's like something I'm trying to work on myself is to be like psychologically flexible, because then I can continue to be like active or stick to my nutrition plan in a wide variety of situations. So I'm very exercise biased. So I think exercise is great. So it's like, if I have a flexibility based mindset with my exercise plan, like over the holidays, I've got exponentially more excuses not to be active and fall off my plan. But if I'm flexible, I'll be able to navigate that and stay on the plan basically. So yeah, and I'll very rarely tell a client, hey, you need to be flexible with your nutrition, you need to be, but it's kind of like, well, if they are, that's a really skilled kind of, client who can really manage their health. Like, because life is so dynamic.
And it would be a disservice to not bring this up, I think. This affects, both of our realms, but in reality, only 24% of Americans meet U.S. physical activity guidelines. Only 6% of that actually meets resistance training focused physical activity guidelines. And when you look at, well, what's probably one of the main variables that's a determinant of literally and figuratively making moves towards meeting physical activity guidelines, it's finances. That's what we see. That number will increase as the person's household income increases. And that we just saw that data from the CDC this year. They have a very compelling chart in which, as you see the median household income go up, guess what? Physical activity guidelines being met also goes up. So I think, especially for the health and fitness and healthcare clinicians, like meeting people where they're at, like not everyone can afford a gym membership. Not everyone can afford a personal trainer. Not everyone can afford a registered dietitian. Like we have to figure out from a community standpoint, how do we access the majority of the population? And the majority of the population is not meeting physical activity guidelines, not meeting dietary guidelines. And the reasons that typically I would kind of be biased towards are social determinants of health, that we have simply not afforded everyone equitable access to do both of those things.
Yeah, wow, that's interesting. So as a family, or is it as a family, or as an individual becomes wealthier, they have more access? Which
It
is it?
was, if I recall correctly, it's household income. As household income increases to the above the federal poverty line, then meeting physical activity guidelines increases in percentage.
And is that separate from or independent from like access to, parks and walkways and different things like that would affect your health outside of income?
I don't believe that particular data looked at built environment, but there are larger. So I recently had a publication in American College of Sports Medicine's journal, Medicine, Science, and Sport and Exercise, that looked at physical activity's relationship with chronic pain. And the survey we used is the National Health Information Survey, which was been ongoing since the 60s. It's the largest survey that samples a general representative population sample of Americans, meaning it covers a wide variety of socioeconomic status and race and gender and so on and so forth to really try to capture broadly, external validity. What are some general claims we can make about the health of Americans based on this sample size? And some people complain, well, it's only, around 30,000 people. I'm like, good luck surveying 30,000 people. That's a general population representative sample. Like that's very hard to do. And they literally go into these people's homes for hours and go through about 500 pages of questions. And it's one builds on the other. I'm totally blanking on the name for the word of that. Like you're taking a test, but each question will build on itself as you answer. And it samples all sorts of things like behavioral issues, like is the person smoking, alcohol consumption, chronic pain, medication utilization. I want to say there are questions in there regarding leisure time physical activity and access and stuff like that, but it's such a large document and I haven't looked at it in a while. I don't want to say, but that's where I would look to see the relationship of the built environment to people actually meeting physical activity.
Yeah, so you're making me think of when I speak to some people, I feel as though I'm very, very lucky in that I enjoy being active. The benefits I get are like abundantly clear to me, but I'm sort of, and I guess a lot of fitness professionals are sort of almost gifted the joy of exercise, I would say. Because I feel like a lot of people, I don't know, is it the environment, experience, or maybe just genetically, they don't enjoy exercise. What was your thoughts beyond that? Do you think that there's people in the population that just do not enjoy exercise, and maybe health professionals do actually, for example, hormonally, the endorphins or something along those lines mean that they're predisposed to enjoy exercise and therefore their adherence is a lot higher as a result?
Yeah, I'm going to stick with social determinants of health. If you're a single mom with 3 kids, you're working 2 jobs to just put food on the table and maintain a roof over your head, you're not really going to have time to worry about meeting physical activity guidelines, and you're certainly not going to have time worrying about dietary guidelines. I think we are often focused on the individual, like, why aren't you doing this thing that we know you should be doing? And it's very hard for us to zoom out and say, have we set up our environment and our society that the individual finds themselves in to ensure equitable access and ability to do all of these things? And then it's going to start getting at, well, should we have a universal stipend for financial income at the federal level for all households? Because that's, ultimately, if we're looking at this, when we see social economic status linked to a lot of health related outcomes, at some point we have to say, how do we adequately address this? Versus traditionally in the United States, in a lot of situations, we put it on the individual. This is your problem to fix. It's your problem that you're below the poverty line. Just work harder, which is ridiculous, right? Like, you can't look at someone and say, well, it's your problem. You should just work harder. Oh, you're dealing with overweight and obesity. Just eat less. Oh, you just need to move more. For the longest time, ACSM's tagline and mantra was, eat less, move more. And it's like, well, are you like thermodynamically correct? Sure, but you're missing the human being sitting in front of you. Have we done the things we need to do as a society to ensure that you have the ability to go do that? Do you feel safe in your neighborhood? Do you feel capable of going for a walk in your neighborhood? Do you have access to childcare to give you the autonomy and ability and time to be physically active? Do you have access? We still have food deserts in the United States. Like, that's wild to me, given, the amount of money we have as a country. There are regions that people don't have access to healthy foods. That's a problem. So, like, what are we doing to systemically ensure everyone has equitable access to this supposed healthy lifestyle?
Yeah, you're throwing up so many questions. There's actually a food desert here in San Francisco in the Tenderloin. It's like a sort of a lower socioeconomic area. And yeah, it's crazy. You go into the stores and it's just full of candy or added sugar foods or those hyper processed foods. So then, somebody who comes in to work with you in the work that you specialize in, if they are not happy with their health, maybe they experience a bit of pain. They know they want to improve their health and get more benefits from exercise, but they kind of are facing all the challenge. Maybe they're, from a lower socioeconomic background. Maybe they have children. They work a lot of hours and stuff. It's kind of like, for me, it's kind of like, does it come down to kind of expectations and being like, look, you're not going to be, athlete, professional level health. You're maybe, your best days are behind you, but now it's a case of like just making the best of a tough situation and managing sort of expectations, but also your health, given the challenges you face. So basically, is it kind of like some people that just won't be able to make a huge improvement in their health, but they can kind of maybe slow the decline in their health, or they can maintain, their health at 40 and just maintain that level of health as they age. Do you get what I'm saying?
Yeah. There's a couple of things there. The first thing I would start with is I probably wouldn't use a professional athlete as an example, because a professional athlete's not after health. They're after a positive outcome, which is winning. And we're willing to sacrifice our health to get that outcome, right? We see that in professional sports all the time. So I don't consider that like automatically a picture of health, which brings me to an ultimate question that we struggle to answer with. Well, can you define health for me? What does that mean to you?
You're asking me?
Yeah.
Yeah. Well, I know the new answer that's out there. That's like, it's a freedom of being free of disease, something along those lines. But it's also like kind of a freedom from like kind of psychological, we'll say, conditions also. But I'm struggling to come to an answer for sure. So I guess if I was to just come up with my own answer of what does health mean to me, and it's kind of just like the easiest answer is to say that it's kind of like you're within the normal range for BMI or the next tier up, the 29 to the 25 to 29, right? And then it would be based around some basic kind of metabolic information, like for example, your blood glucose and that kind of stuff, which is quite difficult for straight away. There's a monetary sort of element to it. So like it would be metabolic, based. It would be physical based in terms of how much activity you're doing on a weekly basis, which would probably be a mix of aerobic and resistance training. And then psychologically, that's probably the hardest one, but it's the most important. So I would say that it's kind of like, how do you define someone being healthy psychologically? And it's like very challenging. So I would just say maybe, it's a really tough one to answer. So basically, I think I'm proving your point here that it's very hard to define what is healthy, but
so you're struggling with a question that many of us have struggled with, and healthcare in general struggles with, and it ultimately gets at system level questions. Because if we're going to say that we're making recommendations to make you healthy or disease free, like we need ability to identify modifiable risk factors and protective factors to these supposed outcomes. So I teach at Bridgewater College. I teach a class titled Health and Fitness Assessment. So my task is to teach undergraduates how to assess health. Well, the first month of the class, we spend talking about how do we define health? How do we define disease? Because I think a lot of people just assume these are given, right? And then we go out into the world. It's just like we assume we know what pain is and how to define it and what it means. And so we go out into the world to affect this thing that we think we've objectified. And these are the things we're going to do to affect this supposed outcome. So what I try to get them to realize is like these are very intangibles, right? And so health has been defined for quite some time by the World Health Organization as, in essence, to paraphrase it, a complete state of physical, mental, and social well-being, right? And so the question I pose to them, I'm like, think about, and most of them are 18 to 24. I'm like, think about your past 18 to 24 years, however much of it you can remember. When were you ever, if at all, at a state of complete physical, mental, and social well-being? And they're like, well, maybe once in 2 decades. And I'm like, right. Like, how do we achieve the unachievable? It's setting people up for false expectations. So then we talk about other definitions. Hubert et al. Came out with a definition that in essence boils down to your ability to adapt. And it's like, cool. So now we're back to blaming the individual. Like, you're not healthy because you're just failing to thrive and adapt. Awesome. So then I take them, I'm a bit into philosophy. Most people would label me an activist, taking an active approach to a lot of topics, which I do take an active approach to pain, as well as the health. Frederick, I'm not going to say the last name correctly, but it's Savias, I believe, wrote a paper about an inactive approach to health. And ultimately, it's does the human have the ability and autonomy to lead the life they want to lead? And in essence, that frees up the person, for the most part, to pursue life as they see it appropriate for them. And so then that will also beg the question, have we set up the environment and society in a manner that allows them to pursue their idea of health in life? And so that is much more of an individual question. So I will often ask people when they consult me, to circle back to your original question, what does that mean to you? What does health mean to you? What are you trying to achieve? What is it you currently are doing that you feel like doesn't meet this standard? And how do I help best facilitate that? The usual discussion is on the same side of the coin, we have disease, which also surprisingly is not easy to define. The field of nosology has been around for quite some time. At the turn of the 19th century, we had the kind of modern biomedical model emerge within the world that, especially in the United States, that states that in essence, any symptom, it can be compiled together with other symptoms to be a sign of the supposed label that we can provide. We call that diagnoses. We have ICD-10 in the United States and throughout the world. It's typically used to label these symptoms or signs pointing towards this diagnostic label. And so biomedicine takes the approach that we can isolate disease at an etiological standpoint and we can intervene and correct it. What you realize is, especially when you're in the philosophy side of things, is there are many different definitions of diseases. And you have things like normativism, which means you have to have a group A comparison to group B, and the group level defines what is normal, what is healthy. But the issue with that is we often have the inappropriate comparison class. So if we were to say like, okay, the average American has a height of 5'9", but you are of Japanese descent, let's say you're 5'7", are you abnormal? Are you diseased? But if we took a normative approach, you're outside of the group norm. We've done this throughout history. We did this with homosexuality. We classified homosexuality as a disease based on normativism. We did the same thing with psychological related issues throughout our history. We classified various mental health issues as disease states. And we do that from a pathological standpoint with pain all of the time. And so when people come to see me, that's the mindset is I have pain or I have XYZ issue. It's indicative of a problem that I need you to solve and fix. It's very mechanistic based, so to speak. And so we have to work through, what are people's basic understanding of these concepts of pain, of health? Where do they see me falling in this? And so I really try hard to reconceptualize these ideas of health, disease, and pain. This isn't to say like we don't have data to help guide this decision making. A lot of people will accuse me of ignoring biology and biological influences on these ideas of health. And that's not the case at all. It's creating more space and time for other avenues beyond just the biological silo. And so, like you mentioned mental health and well-being, that will afford more space and time to address those more what people call soft issues versus let me just see what your basal metabolic, rate is, or what is your cholesterol levels. Like, are those things important to an extent? Yes. But we have to remember the human is the one with the cholesterol. The human is the one with the pain related issue. And so we have data to say, like, yeah, if your total cholesterol is above this number, we're increasing your risk for cardiovascular disease as an outcome, which is just an umbrella term for increasing your risk for things like myocardial infarctions or cerebral vascular accidents. Are there things that we can do to bring down that risk, to mitigate these negative outcomes we don't want to happen to you? Sure. Physical activity, dietary guidelines, great steps to take. Maybe you have a genetic predisposition to have familial hypercholesterolemia. You're probably going to need co-management with medication in addition to these other things. That'll still reduce your risk. Does it ever go to zero? No. The ultimate outcome, all of us flee away from, but are in actuality fleeing towards, is death. It's unavoidable. That is the end outcome for all human beings. So when we're constantly like, well, what can I do to minimize that from happening? And it's like, we really don't have a lot available to us. We have some really cool medicalized silver bullets like vaccines, antibiotics in certain situations, trauma situations we're pretty good at helping, but we don't have a lot of that, right? Then, it's trying to figure out in a long-winded way, like, how do I help this person achieve their idea of whatever we're discussing? And what do we have data to actually support and me making those recommendations, which is why I don't do things like spinal manipulative treatment or cupping and so on and so forth. So I feel that was a very long-winded response to your question.
Yeah, no, that's brilliant. It actually answers the first question I was going to ask is what work do you specialize in? And I feel like you've just made a clear point about client empowerment and education and kind of like process as opposed to giving them a special treatment, which, you can treat someone with the cupping or the spinal manipulation, but like really how much does that affect long-term outcomes? And I would say just personally, I don't think it's going to be as effective as educating the client.
Yeah, it's interesting because just like when you're talking about modifiable risk factors for heart disease, if we're talking about modifiable risk factors or protective factors for pain, there's not a whole lot. Pain's an inevitable aspect of human living. That's just a fact of life. But the good news is, so are other things like love and happiness and joy. Like we have the ability to feel a wide spectrum of ways, right? Pain just happens to be one of them. And so can we affect an outcome with various interventions like cupping, dry needling, spinal manipulative therapy, exercise? Yes. We can get a numerical reduction in a pain rating scale and a whole host of factors. My question is, what narrative do you have to supply as a clinician to the individual to do that intervention? What are you making them believe about pain, their body, themselves, and the world around them to validate your intervention? And if it's pseudoscientific, like bony misalignment, well, that really only happens in very particular scenarios. Does someone have a bony misalignment? You can have a full luxation, which is a dislocation, which you've luxated a joint and it needs to be relocated. You could have a subluxation, which is just a partial dislocation and then pops right back into place, not the chiropractic narrative of subluxation, which is these minute millimeter misalignments that only a chiropractor can find. We don't have data to support that. And that typically occurs in very specific scenarios like Ehlers-Danlos syndrome, EDS, in which you have hyper range of motion, hypermobility. And you wouldn't be doing joint manipulations to correct that type of issue. So it's just figuring out, if I'm making up narratives that I don't have data to support, I'm likely over medicalizing and pathologizing. I'm making up reasons to explain your pain and validating an intervention, which ultimately is profitable for me to do. Like, you're not going to get a huge return on education. And some professions don't even have access to a CPT code to actually do CPT codes, just the codes we input to insurance companies to get reimbursement for a particular ICD code. A lot of professions don't even have the ability to bill out for education, right? And so if I'm telling you, well, you have low back pain because you have muscle knots and you need me to release those for you, then we don't have data to support that. Do we have people subjectively reporting sore spots or pain in particular areas? Sure. Have we created objectifiable diagnostic criteria that's able to be repeated and replicated over time and is valid between clinicians and professional titles that then demonstrates, yes, this supposed issue exists? Not only does it exist, but it increases your risk for some negative outcome, let's just say pain in this context. And then not only does it exist, increase your risk for supposed outcome of pain, but we also have meaningful interventions that can directly intervene upon the etiology of that issue that has greater benefit than risk. Because a lot of people think intervention is just an upside, but there are risks to intervening on people, right? And so if the risk of intervening outweighs the potential benefits, then we don't do that intervention. And it's just like, well, this is what it is. You have to live with this. Those are the types of steps we should be going through as clinicians. Do we have the ability to identify X? Are we able to repeat it, replicate it, and demonstrate that it's a valid diagnostic criteria? Does you having X increase your risk for some negative outcome? Do we have the ability with some treatment to intervene directly or indirectly on that variable to decrease your risk for that negative outcome or to treat the symptoms of that supposed issue, and doing so that there are more benefits than risks? And typically we skip all these steps. We just say someone reports pain, we can make up a diagnostic criteria for it, and people run off with it. It's very marketable to say this title has this ability to diagnose X, and only they have the intervention to address X. That's very capitalistic approach.
Yeah, it's very like black and white, and I feel like health is just like we're trying to define, or I'm trying to define health is very gray. So it makes me think, is getting a client to kind of conceptualize what their version of health would look like for them, or trying to define what they're trying to work towards, to get them to think about, okay, here, so I've decided I trust Micahel, I'm going to work with them. Is it important then to define like what would be a positive outcome or like a vision for their health?
Absolutely.
Or is that even necessary? Could they just kind of, blindly come to you and just, show up and they would improve their health anyway without defining it,
Yeah, so I don't think health is like this static, objectifiable, variable for the most part. Like I think at best we can say mitigating the ways in which we die typically, which is heart disease, is number one time and time again. So it's like, what can we do that we know are modifiable risk factors towards these things that we just hope don't happen to you, or at minimal or less likely to happen to you? And so usually people come to me with a lot of priors, like, hey, I've heard I should do Orange Theory Fitness. Hey, I heard I should do CrossFit. Hey, I heard I have to do barbell training, squat, bench press, and deadlift or keying. Hey, I've heard I have to go do F45, whatever the latest. And I'm like, look, A, do you like being active in groups or alone? Do you have the financial expendable income to join those various, organizations and gyms? Do you have your own equipment at home? What does physical activity mean and look like to you? What do you gain enjoyment from? Because here's the data that we have. I'm meeting this very squishy idea of health. Physical activity guidelines, 150 to 300 minutes per week of aerobic activity at moderate intensity. We have to talk about how do we gauge intensity. 75 to 150 minutes per week at vigorous intensity or a combination thereof. And 2 days a week of resistance training for all major muscle groups. From a physical activity standpoint, that's all we got to say that we can meaningfully affect this squishy idea of health, which ultimately is just minimizing the likelihood of disease-related outcomes like heart attacks and strokes from inactivity. And it's to the point where it's not really that exercise is medicine, it's inactivity contributes to the development of disease states. And so that's what we kind of talk about. I'm like, if you've been doing nothing in the prior 6 weeks, so you've been inactive for years on end, A, I'm not going to take you from that to immediately meeting this criteria. But B, we can meet that. It's purposefully vague in a wide variety of ways. So if you like CrossFit, if you like Orange Theory Fitness, if you think SBD is king, awesome. We'll start making programs and moves towards doing those things. But if your goal is just health, you have a wide variety of ways to meet that. If your goal is, I want to be strong, we have to talk about, well, what does that mean? Strength is task specific. Do you want to go compete at powerlifting or weightlifting or CrossFit? Is that just, I want to be strong enough to lift up a bag of dog food and walk it from my car to my house or pick up my grandkids? We have to define what that means to them. And then how do we program specifically to help them increase strength for those tasks? So those are the type of discussions we have is really, and it's the same thing when people see me for pain, is addressing prior narratives they've been given about the supposed outcome they're trying to affect. And what do we actually have data to say we need to do to achieve those outcomes?
That's brilliant. Yeah. So it's making me think that I should definitely, define health for a lot of my clients because, I kind of have that belief that exercise is medicine. But can you just talk a little bit more about how you said exercise, it's not necessarily medicine. Inactivity increases like disease risk and the chances of disease states. So it's a bigger risk factor to be inactive than it is. There's a bigger benefit to just kind of blindly being active. Is that right?
Yeah. So I think about it like a spectrum. And so because the majority of our population is inactive, and we also have about 50% or more that fall into the classification based on BMI of overweight and obese, that is where we usually think on the spectrum that folks just aren't active enough, and that's contributing to the disease state. But that doesn't then mean we just need to increase activity ad infinitum, because there are risks on the other end of the spectrum, like RED-S, relative energy deficiency syndrome, which often falls in endurance athlete populations, of being physically active to the point that you're developing underweight BMI status, low body fat percentage. You're having amenorrhea in female athletes. You're having lack of morning erection in male athletes. Like these are symptoms that are signs of relative energy deficiency syndrome. So, and you can also have an increased contribution to having bone-related issues, bone stress injuries, so to speak. And so it's on a spectrum. I just need people to be physically, like, I am so happy just getting people physically active and moving more on a regular basis in ways that they find enjoyable, that meet their goals for life. Because personally, and I know I'm going to narrow frame this, but when I look at social media these days, we're talking about what's the sweet spot for ultimate hypertrophy? What's the exercise that's going to target this specific part of the hamstring groups? And I'm like, folks, we have only 24% of our population actually being physically active. That's not trying to minimize that. I think for a very small percentage, ultimate hypertrophy for my bodybuilders and figure competitors, that matters. But it's a very small subset, you know? And so it's like, I'm more focused on how do we get the rest of these people to be able to be afforded the opportunities to engage in what we consider to be healthy lifestyle behaviors, and very much less focused on this minutia of what we seem to think is important in health and fitness on social media these days.
Yeah, the minutia for sure. Like, there's such a big trend or bias, or I don't know, just kind of overemphasis on fat loss in the fitness community. It's as though fat loss is king. Your body weight is all that matters. Having, the bigger your muscles are, the better. And just like we kind of talked about earlier, it's like, well, your health is made up of like your mental health as well, not just your physical or physiological health. So do you see that a lot with your clients? And kind of just what are your thoughts around, that idea? Maybe I have it wrong, but that fat loss is overemphasized in the fitness community.
Yeah, I think a lot of people talk to me about wanting to look a particular way. And I do try to reframe, like, also, how do you feel about yourself? How do you clothes fit? Do you like the way you look? Are you happy with yourself? I try to have a self-love kind of approach, because I'm like, what do we think is going to happen? Okay, you drop your body fat percentage low enough to have a six pack. Does the world of nirvana open up and suddenly you're a millionaire and you have these fancy cars? Like, why are we doing what we're doing? Is it truly because that's what you want, or is it because society tells you that's what you should want? Which is a whole nother discussion on free will that we don't have to get into. But yeah, I think that there's a major focus on for both sexes, men and women, that you have to look a particular way. And you can even see it on many different social media platforms. I have a student that actually wants to we're going to do a qualitative study on TikTok, analyzing the perception of an advertisement of fat burners, which gets out kind of what we're talking about, like why are fat burners sold, under what narratives, what's the evidence, what's the ingredients, what are people's perceptions of these products being sold. It all started because we started talking about, she found some tea on TikTok that was being sold as a fat burner tea. Like, all you got to do. And I was like, look, the reason it works is because you're in a fucking caloric deficit. Like, all you're doing is drinking tea. You went from eating 3,000 calories a day to having 6 glasses of tea. Like, yeah, I mean, I'm happy you don't die in a couple of weeks, but yeah, you're good. Right. And so it's just having these conversations about, are these advantageous ways to go about weight loss? Do we need to do weight loss? What are we trying to accomplish? How does that feed into your idea of health? How you view yourself? What do you as the individual actually want to accomplish? And maybe you've built out these narratives based on what you've seen on social media told by others, and there's not a lot of evidence for them. And in fact, they could be quite harmful if you get on these paths unnecessarily.
It's funny you mentioned that, actually. Yeah, I have a good friend who might be listening to this, and basically he was asking me about supplements and fat burners, and I'm just like, none of it works.
Yeah.
Like, there's no evidence to say that any fat burner works, like, reproducibly over the long term. And any change you could get with a fat burner, you could save your money and get through better habits, or you could actually get a better benefit by focusing on other parts of your health outside of fat loss. So it just makes me think.
Sorry, go ahead.
So it just makes me think of, again, coming back to like client kind of like education and empowerment. And it's kind of just like, once you've been in the industry long enough, in my experience, it's quite easy to spot the real from the fake, or what's, a trend versus what's actually like a fundamental, health principle. And, my friend would ask me a lot of questions, and I would be able to just cut through them so easily, like in general, most things don't work. There's only a very few set of kind of fundamental principles that do work, right? So it's kind of like, is that something that you would work on, like with clients, kind of constantly sort of reinforcing, I guess, the fundamentals of health? And if so, like, is there anything, what are kind of some of the main principles you try and pass on to your clients that you work with?
Yeah, it's certainly related to health, which for me, in my context with Tame Pain, often falls under how does pain fit into this idea and concept of health and disease. So there's a lot of reinforcements. I would just add, in the context of body composition and fat loss, there are some really good physicians out there that specialize in obesity related practice. And I think there are appropriate contexts for people that they need medication management. They potentially would benefit from surgical intervention and management, and accompany with these other healthy lifestyle behaviors. I think there is a lot of nuance that's not my specialty area related to the development and sustainment of obesity. And I don't want folks to hear like, all you have to do is eat less and move more. I think there's way more external factors that are related, and there's a time and a place and appropriateness for co-management from those folks that can help people achieve their goals. I think that there's a misconception that even at a genetic standpoint, that all of us have equitable ability to achieve this supposed healthy outcome. And I don't think that's the case, right? And I think especially in the health and fitness world, like that's what a lot of people sell under, right? Is like, oh, I look this way, come work with me. You want to look this way too.
Sorry to cut you off, but it just makes me think, right? We would never say, Michael, you could be a professional athlete in X sport, or, we wouldn't ever look at people like that. But we always look at ourselves and everyone else and say, you can lose fat, you can be of a healthy weight, or at least subconsciously we believe that. And it's just like, we never would do that with something like an athlete. And there's so many sports out there. Surely someone could become a professional in any sport. And yeah, it's just kind of like, but for fat loss, we kind of have the same idea. Oh, you should be able to lose weight. Why can't I lose weight?
What's wrong with you?
What's
Yeah,
wrong with you? Just eat less, move more. And it's just like, because there's so much more at work than just eat less, move more.
exactly. So I think like having more space and time, building out connections, like referral connections, say, hey, I think, this obesity specialized physician could be very helpful in this scenario because your risk is certainly going to increase long term as we progress through class 1, class 2, class 3 obesity. We sustain that over time. But I think it would be very patient blaming to be like, well, this is your fault. You're not eating less or moving more. When we have very real, tangible, and from what I've been told by colleagues, low risk medication management and surgical procedures that could help this person along. For me, the past 2 years has been a realization of like how impactful mental health can be on my quality of living. I've dealt with general anxiety disorder for most of my adult life. I've been very transparent and open on social media about it, but I had a sticking point for the longest time that medication management was a failure on my part for managing my anxiety. I should be able to do it through appropriate quantity, quality sleep, through physical activity, through mindfulness techniques. And a friend at the time said to me, he's like, why do you view medication as not self-management? And I was like, wow, that's a really good question. Why do I look at it like that? Well, the people that were around me looked at medication as like, I'm failing, right? Like I needed outside help. It's like, no, this is just a part of your co-management so you can take care of yourself and elevate your quality. Why would you force it upon yourself not to utilize this? And that really reframed it on many levels. Like, I think if you would have talked to me, I got into the health and fitness field in 2003, early on working for a gym and then progressed throughout time. I would have been like, oh, you shouldn't have to do that. Like, you should be able to. And it's like, wow, how naive of me, how narrow-minded of me to think all of us have the same affordances and abilities to achieve these ideas.
Yeah, that's a great point. And just something I want to come back to as well is like, being lean and the effects of it. And you're talking about the red S syndrome and stuff like that. And it's just like, just when I think from my personal experience, when I was at my leanest, it's like my life is miserable. So it's
Yeah.
like, so you don't want to be lean. You literally don't, your body doesn't want to be lean. Your social life, you don't want to be lean for your, any aspect of your life. If your body fat is like as low as it could possibly be, and I mean like if you look as lean as you possibly can and you think that's the gold standard for health, it's actually the opposite once you fully experience it. So you don't want to be that lean. I would just kind of put that out there that people
Yeah.
overemphasize the benefit of it.
We have essential fat recommendations at 3 to 5% for men and 8 to 12 for women. And like you drop below those numbers, like essential fat is necessary, right? Like insulates our organs, helps with thermoregulation. We utilize it for energy production. Like there's a reason we have adipose tissue. So, I competed in bodybuilding. I did a show and the last time I did it was 2012 in an NPC show. And it's like, yeah, you're at, what I would label as your unhealthiest. Yeah, I'm completely dehydrated. I'm at the lowest body fat percentage I've ever been at. I feel fucking horrible. And so it's like, well, why are you doing this? Well, if it's a goal that is important to you and you want to achieve it, I'm happy to facilitate it. But that doesn't, I would be difficult to agree that that's the picture of what we perceive in our society as healthy living and achieving these positive outcomes of health.
Yeah, absolutely. Like I wasn't that lean. When I got my body fat tested, it was like 9% when I did a DEXA scan. So that's not bodybuilding lean. And even then, my life, it's funny because at the time I didn't realize. I thought, oh, I'm lean, the sense of achievement, external validation. But it's like I had no social life. My relationship with food was terrible, energy,
Yeah.
couldn't really do much. So yeah, I think leanness is just way overrated. And then just, yeah, touching on like the mental health side of things as well. It's like I have a family member who uses medication for mental health, and has seen a very good benefit. So it's kind of like, I almost think health is kind of like a hierarchy, we'll say, and your mental health is the foundation to it, and exercise is sort of like, it's essential, but it's like not the foundation, or it kind of supplements the psychology of your health. So that's that taking that broad, 1,000-foot view of your health.
Yeah, I don't think it's a panacea. I think it can help us move towards these concepts and ideas of health and mitigate some negative outcomes we don't want to see happen to people, like heart disease and stroke and heart attack. But I think there are many other things that are going to be needed in people's, pursuits of their idea of health. From my perspective, pain related, because people are like, oh, you just educate and exercise. And I'm like, I actually don't even advocate for exercise. I advocate for physical activity because a lot of people shy away from this idea of exercise. I'm like, but I don't make any claims towards physical activity correcting something that's wrong with you. Like I'm currently I'm almost at saturation, a qualitative study on what are clinicians' beliefs about people who consult with them for their low back pain. And it's a lot of patient blaming, like a depressing amount of patient blaming. Like you're not active enough, you're too active, your muscles are too tight, your muscles are too loose, you're not strong enough, all you do is strength train, you're not flexible. I'm like, holy shit. Like, why has it become like you're in pain because you're doing X wrong? It's all your fault. Like, how do we reframe this from you're the problem and I'm here to fix you, which is a whole nother conversation. But we actually don't have data to say like you have to, just like with health, we have no data to say you have to do a particular mode of activity. You can, what my most recent publication showed is it's probably a good idea to make moves towards meeting physical activity guidelines to mitigate the risk of chronic pain development, or to add as an accompaniment to helping folks dealing with chronic pain. Like that's the extent we can say is just trying to pursue physical activity guidelines, which is probably a good thing because then it gives that individual autonomy of frequency, volume, intensity, mode for things that they enjoy doing, but we'll also get the added benefit of pain relief.
Wow. So even though you exercise regularly yourself, you wouldn't advocate for clients. I guess what would your recommendations be for exercise? Because I would be like of the opinion, I guess I'm so biased though, right? That I already said I get such a benefit out of exercise, but that's individual to me. So I should be very careful about how my language with clients. So what do you recommend to clients in terms of, especially with pain, like the tough situation of I have low back pain or I have pain in this area. My thing would be like, I'm almost of the belief that exercise is like analgesic, but it's, that's a huge claim to make. That's pretty wild. So what do you recommend?
Exercise could also increase someone's pain. Like it's a spectrum for sure. So the statements that I make, and so like for those who go and pull this recent publication, it's just the relationship of physical activity and pain in United States adults. It's in ACSM's journal. We were very purposeful in our language, and we say physical activity, not exercise, throughout the paper. Exercise is planned, regimented, goal-oriented based programming and training. Physical activity is any bodily movement that's accomplishing a task, which could be activities of daily living, could be extracurricular or leisure activities. It's any bodily movement that demands energy.
Come into that? So non-exercise activity?
Yeah. Oh, yeah. It would fall under the umbrella of physical activity. Yeah. And so we say, this is why they're called the physical activity guidelines, not the exercise guidelines. It's because we just need people being physically active. Like our bar is so low. We just need to get people moving. We don't need them actually exercising. Great. You want to be regimented. You want to have a very specific goal for your physical activity. We call that exercise. I'm totally happy to help you do that, but we actually don't need that. And it helps minimize these ideas of like, oh, I have low back pain and Stuart McGill says I need to do bird dog, dead bug and planks in order to correct my low back pain for XYZ reason. Like we have no data to say that or support that. We can say confidently that physical activity for many people feels better, but you can move in a wide variety of ways that you find pleasurable and enjoyable and meet your goals. It doesn't have to be these magical big three exercises.
Brilliant. Yeah, that kind of actually makes me feel like, or reminds me of a point. I feel that, the longer I'm in the fitness industry as a health professional, the more I'm like a gatekeeper for exercise. And what I mean is people have these like notions of I have to, or physical activity. I'm a gatekeeper for physical activity. So people are like, I want to get healthier. I have to exercise in a certain way. You're going to show me how to exercise. And I'm really just going to keep you accountable, really, you know? So my sessions with clients have gotten a lot more like broad, open, conversational, where it's just like, I'm just going to make sure you do something. And whatever
Yeah.
you want to do is what you're going to do. And that's going to get you a benefit, you know, because you're currently, you know, the 24% of people meeting the activity guidelines. So it's kind of like, I'm just going to get you closer to those guidelines. So do you ever kind of feel like that, where you kind of giving permission to clients to just move, because
Yeah,
the modern
especially
lifestyle, you know, it's quite inactive.
especially in pain related scenarios. So when someone experiences pain, it's oftentimes asking the question of, is this normal? Should I be experiencing this? Do I need to avoid movement and activity? Because pain is often associated with some specific task or some movement. And unfortunately, a large percentage of clinicians approach pain under what we call a kinesiopathological model, KPM, which is just a fancy way of saying you moved correctly or incorrectly and you got the outcome of pain. Don't really have data to support that. We don't have the ability to say if you move a particular way, you're at increased risk for the outcome of pain. And if you move a particular way, you're at a decreased risk. It's protective of the outcome of pain. We don't have that data. But if I approach your pain scenario as you moved incorrectly, you sat incorrectly, you walked incorrectly, you lifted incorrectly, then I create this one way of doing things perfectly. And as we know, with any dynamical system, building robustness and resiliency is done so through variety. So why would I constrain you down to one perfect way of doing things? I actually make the system weaker. It doesn't make a whole lot of sense, but that's how a lot of clinicians approach pain and movement. And then we don't have the supportive data to do that. So it's very much giving people permission to move and live their life and try not to focus so much on their symptoms unnecessarily, which can lead to fear avoidance behavior. We call that kinesiophobia. And that just means you're fearful of movement for anticipatory anxiety for the outcome of pain. So you stop doing things that you'd value and deem important for the fear of the outcome of pain or from the fear of increasing your pain. And we know that this is one of the major contributors to the development and sustainment and reoccurrence of chronic pain. And chronic pain is just simply defined on a temporal basis. It's pain that's lasting longer than 3 months. And so that's it. That's the only criteria. It's a temporal based criteria, and it's an arbitrary temporal based criteria, right? And so if that happens, though, we see the persistence and reoccurrence of pain oftentimes because of the narrative someone's been given that they believe about their body and pain in themselves and how they engage the world around them. So we have to go through this process of, just like I asked you, what do you think health is? It's, well, what do you think this pain is? What do you think pain means? How is the pain affecting your daily living? And I hear things like, well, so-and-so told me I should stop doing X, and so-and-so told me I was doing X incorrectly, and that's why I'm getting pain. And they start constraining their ability to live their life accordingly way down. Well, as humans, we are our beliefs and behaviors. If I take away the behaviors that define your identity and who you are, yeah, you're probably going to become depressed. You're probably going to become anxious. You're going to feel less like yourself. You're going to have your identity stolen from you. And so part of my job, it's coming in and opening up affordances, which is just kind of highlighting things in people's daily living to say like, hey, it's okay to have some symptoms. It doesn't mean X, Y, or Z. It's okay to re-engage these activities that you value in your life because it's part of your life and what makes you you. And we have no data to say you shouldn't do X, Y, or Z. And so that going through that process really helps someone reconceptualize pain, the meaning thereof, how they view their own body, how they view their environment around them. And as they re-engage the things that they value and want to do, they find that their focus of attention is no longer on their body as much. The body should be this transparent vessel that lets me engage my world accordingly. But when we're experiencing pain or what we may label as disease, the body takes the foreground and it kind of obfuscates your ability to focus your attention on anything else. And we have to kind of work through this process to get your body to fade back into the background. And your attention is just on engaging your world. It's almost like learning a new task, right? Like if you think about learning to ride a bike or learning to bench press or learning to squat, learning any motor task, you're super focused on the minutia. And you're even more so if you have a coach that's like, make sure your back's doing this, make sure your knees aren't doing this, make sure your head's in neutral, make sure you're doing that. You're like, fuck, I'm focused on every single joint I possibly have versus being able to focus your attention just on task completion and not worried about all of these minute details. That makes you feel more confident in yourself, more capable, and eventually more like yourself. The difficult part of this is you don't change beliefs in a single conversation. It's a process.
Yeah, absolutely. You're making me think of public speaking. That's like my, a challenge for me. And I try to remind myself to focus externally, because when I focus on myself and I'm speaking publicly, that just messes up me trying to do the completion, like you said.
Yeah.
And that's, I guess, where I enjoy exercise so much, because I almost get out of my head and into my body or something like that, if that makes any sense. And yeah, I can really just be present. So something you mentioned is that, people's narratives, and that maybe I kind of feel like you were saying it, but you didn't directly say it, is that like people, okay, this is my opinion, that people have this sense that they're weaker than what they actually are, and that they can't be as active as they would like, or that pain is so real, whatever pain they may feel, for example, low back pain, that they can't be their true selves or live the life they want to live.
Yeah.
Would you agree with that? And where do you think like this kind of the kinesiophobia, the word you use, where do you think that comes from? Because I feel like it's very pervasive. Is it the modern lifestyle? Like, what's a source for this sort of avoidance of being active?
Yeah, so I think in the context of pain, a lot of it hinges on how we approach pain in our society. And so we very much approach it in a biomedical manner. We think pain is a sign of damage, hurt, harm, avoid, and problem to be solved by a clinician. So we go to our healthcare professional. The unfortunate scenario is our healthcare professionals are very well trained at specific scenarios, infectious diseases, communicable diseases, very well trained at traumas, stuff like that. Not so much on pain. Pain is the number one reason someone seeks healthcare in our country. And the majority of our graduate level healthcare programs do not have a single class on pain. It is this assumed given that's a sign of a problem that needs to be fixed by the clinician. And if you were to pin down healthcare professionals like, hey, what do you think pain means? Can you define pain for me? They would really struggle to do that. And it's like, well, why does it matter? Well, it matters because how you define this phenomenon influences your thought process and management strategies. So if you think pain means X, then your recommendations are going to be built off of that foundation. And whether you've stopped to ask yourself, what is your philosophy of pain? It's there. It's influencing your decisions and it's affecting it. So I try to encourage clinicians like, hey, a lot of, where my research tends to focus these days is what is the clinician's role in the development and sustainment of chronic pain? And I am seeing in one of my biases, we play a pretty important role and not in a good way. It could be in a good way. I'm hoping I can help with the other team members I work with, get clinicians to realize like your role could be pivotal in a very positive way. But my bias is right now, it's not in a positive way. We supply a lot of false misinformation about explaining pain to people. And then the narratives we give them for management strategies are not well founded. And it leads to people having misbeliefs about their body and pain and what it means for how do they engage their world again. And that's how we get kinesiophobia and fear of avoidance behavior. My bias is it's a major clinical related issue, but it is also, if I zoom out, a societal overhaul of what we as a society think about pain.
Yeah, you're making me think of the Hippocratic oath of, do no harm. That's the first thing. And it's kind of just like you said about, choosing your words wisely. And it's so important.
Yeah, we have the nocebo effect. Have you heard of the nocebo effect?
So I know of a placebo effect. Correct me if I'm wrong. Is you're engaging in activity or taking like some sort of like medication and believing that it works and then bringing about a positive outcome. Does that make sense?
Yeah, so we're starting to slowly shift our language, and this is a pretty highly debated topic in the world of healthcare, but I tend to say placebo-like contextual effects. So we can get a positive outcome for a whole host of reasons that has very little to do, if anything, to do with the intervention. And a lot of it's related to therapeutic alliance. Like, do you trust me? Do we get along pretty well? Do I have positive reviews online for my clinic or myself? It could be we trust one another. I confirm to your priors as far as like what other clinicians have told you is wrong with you, and I have the intervention to fix you, and you buy into that. People can get better for a whole host of reasons. I often talk about it about Beverly Hillbillies. The grandma on the show developed her elixir for the common cold, and she was going around selling it to people. And some doctors were like, you know, what are your recommendations? She's like, well, get plenty of sleep, drink lots of fluids, take this elixir 3 times a day. In about 7 to 10 days, you'll feel right as rain. And it's like, well, no shit. The common cold resolves itself through natural history in about 7 to 10 days. And natural history, for those listening, is just if we do nothing, what is the trajectory of this supposed issue? And we see that a lot in chronic pain scenarios. There is a natural history for a lot of people. There's also not a natural history for a lot of people. And I think that we're ruining natural history through the nocebo effect. And nocebo effect, if placebo means I shall please, meaning we get a positive outcome related to placebo-like contextual effects, nocebo means I shall harm. And I think our narratives, our words, our explanations, our validation for particular interventions, we tend to see just upside positive benefits, but in actuality, I think the risks are outweighing that.
Yeah, it's got to be, I think, individualized, any kind of treatment or activity we engage in, which makes me think of like trying to have a philosophy, like I think you kind of said it, where philosophy for pain or philosophy for health or definition of pain or definition of health, be clear on those things and know how it can be affected positively or negatively. So Michael, I've taken enough of your time. Thanks very much. This has been like a really interesting discussion. Is there any kind of final message you want to pass on, or any links or anything that you want to mention?
If anyone's looking to work with us, just Tame, pain.com. That's our website. You can find all of our social media links there. And then I would just, caution people, be careful who you look at as trusted sources of information. We should question narratives and the evidence that is utilized to validate those narratives, regardless of title.
Yeah, definitely apply some critical thinking and don't take things at face value. Think about the source of the information. Thanks very much, Michael. It is that time of year again where a lot of people look to make health improvements, health changes, or they're just trying to get out of the hole that was the Christmas and holiday period. If you are looking to improve your health in 2023, book in your free consultation via the link below attached to this podcast episode. We will discuss your current health challenges, what you're trying to work on, and how I can help you improve your health in 2023. So if you're serious about improving your health, book in your free consultation today and let's get started working.